Professor Ulrich, thank you very, very much indeed for joining us. I listened to your press conference and you were talking about coming from the States back to Germany, and you're setting up at the German Cancer Center a prevention unit, a research unit presumably. So tell us about it all.
Well, in fact, it's actually the Division of Preventative Oncology. Okay. So it's I think a title that hasn't even existed in Germany before, the first division of that title. And it's both at the German Cancer Research Center, the DKK.
In Heidelberg?
Yes, as well as what's key, the National Center for Tumour Diseases, so the NCT. So I'm also a director of the NCT, responsible for the area of prevention.
How do you start dealing with this situation? This is a vast area. It's moving very fast, particularly thanks to Heidelberg and Heidelberg, Zurhausen and HPV and cervix, but also lifestyle. And where do you start setting up a new division?
I should say that, there are already, of course, epidemiologists in Heidelberg, very renowned epidemiologists who have been done work in prevention. And so my task is not to cover everything. I do build on my own research, which I've done in the States. And so there's a lot in the areas of diet and cancer prevention, as well as diet and cancer survivorship, and also physical activity, cancer prevention, and physical activity and cancer survivorship. So I start with the areas that I have, and then I plan to build as I see also need in Heidelberg.
Are there big studies ongoing that you're going to come into that have been planned and executed?
Yes, I think the key study that we're starting here is a collaboration with the United States, and that's the ColoCare study. Right. It's a prospective cohort of colorectal cancer patients, and we want to use a very interdisciplinary approach to study all the factors that are related to prognosis. And so we have a collaboration with many researchers who work more on the basic science level, do proteomics, epigenetics, gut microbiomics, and my contribution is more on the lifestyle perspective, linking in also supplement use, NSAID use, physical activity, etc. Aspirin
comes under NSAID.
Yes, exactly. I think, with...
So these are patients who've had cancer of the bowel, they've been treated, and they're in remission? Or is it a mixed bag?
No, we recruit them right when they come in prior to their surgery, because we really want to factor in also the tumor characteristics, the gene expression profiles, etc., and try to understand how do lifestyle factors influence tumor characteristics, how does that in turn affect outcomes, and how do a number of factors interact in terms of prognosis, because everybody had looked at this in isolation up to now. One researcher looks at one gene just proteomics, and I think the new strategy is to try to bring the best heads together to do a comprehensive approach.
So it's not exactly population-based, but it's cancer center-based, or...
It's hospital-based, yes.
Hospital-based. Primary referral centers or secondary referral centers?
At this point, it's just where we have our collaborators. So
where are they?
So in Seattle, we have the Fred Hutchinson Cancer Research Center working with 3 different hospitals. At the Moffitt Cancer Center in Florida, we're working with 2 different hospitals. And here in Heidelberg, it will be at first the University Clinic as well as another hospital in Heidelberg.
Have you got enough centers?
We would always love to have more. There is actually a colleague from the Netherlands coming, Ellen Kampmann, next week, and we certainly hope to build collaborations all across Europe. I think I have to start somewhere, and then I'm very happy to think larger.
The European Institute of Oncology in Milan isn't so far away, and we might come and
yes, I would actually. That would be very interesting.
You talked about lifestyle, diet, exercise. Is that it, or is there more to it than that?
Well,
what about breast and this, age of having your babies and breastfeeding and so on?
Well, there are many, many, many lifestyle factors that are related to carcinogenesis. What I've been doing when I talk about exercise, for example, is studying this also on the molecular level. So what does it do to biomarkers of cancer risk? Physical activity is a great example of where we know it's good for you, but we know very little about why exactly. And that means also studying effects on C-reactive protein, how does that interact with genetics, etc. So it's a little bit broader than just diet and exercise. It includes the molecular approaches as well.
And the molecular basis of obesity?
Well, we certainly keep an eye on that. I think it's interesting how mouse studies have not translated into human studies. What we do in a study that I still lead in the US is we take adipose tissue samples. So we're trying to study gene expression in the adipose tissue and how it changes with exercise, and maybe get some clues about obesity that way as well.
Well, the whole insulin receptor area is really hot at the moment.
Yes.
I can't believe it's not going to link the two areas of obesity and cancer.
Well, in Heidelberg we have a great expert on that, Professor Cox, so I don't feel like I need to study insulin because he already knows all about it. Yes.
And he's got it.
And then he's a collaborator, of course.
And then the HPV story, how's that going along? Presumably it's still going on post-Zurhausen?
Well, HPV is a very, very important topic in Heidelberg, and it's not been something that I have dealt with in my past very much, so it's something I'll probably have to pick up, but I can't comment much on it at this point. Besides that, of course, in the Division of Preventative Oncology, we try to support health promotion programs for screening.
Good. We interviewed Professor, now Sir John Burton, on eCancer TV not very long ago, when he came out with his definitive answer to the aspirin trial, which was really remarkable.
Very important.
Absolutely
very important work. I was very glad that
it was one up for those who believe in long-term funding.
Yes.
It was one down for intermediate biomarkers, however,
yes.
And the adenoma story turned out not to be so reliable as an endpoint for a real intervention study. What do you feel about that? You were talking about biomarkers in your press.
I think, we do need to go the step of biomarkers in some instances simply because of the reasons for cost. But aspirin is a wonderful example where we do have effects both on the intermediate polyps as well as now on the long-term effects on cancer risk. And I'm very glad that Cancer Research UK was able to fund the extension of some of these very, very important studies.
I think the answer is that they didn't.
Oh, they didn't? Oh!
But despite the fact that they didn't fund it, they stopped the funding, and the government stopped the funding, they still gave John a knighthood in the honours list. So that was really good. So he came up on top at the end of the day. So.
Well, that's very disappointing to hear because it's so much money that goes into establishing the trial in the first round, and then doing the extra long-term follow-up is relatively small in relation to the scientific knowledge that can be gained.
Yes, sure.
So I don't know whether you can do anything, but that's just my perspective.
Good. All the very, very best in Heidelberg. It's great to see you in Europe, yes. And I'm sure that the collaborations will flow.
Yes, thank you very much for inviting me. It's been fun talking to you.
Thank you.
Okay.